First of all, thank you all for taking the time out of your Saturday to join us here to talk about a very important topic. Black breast health is something that's very important, and I'll go through the statistics in a second, not to scare everyone, but just so that we're all aware of how this affects our community, because it does affect our community more than it affects other communities, even more so than it affects other minority communities. This is meant to be very interactive, so feel free to raise your hand, ask questions, stop me if things don't make sense. I want to make sure that you leave here feeling that you learned something and that you can actually make a change for yourself, for your own health, and for your family. Okay? Few acknowledgments. I have no disclosures. I am doing this through a Stanford grant that allows me to do monthly seminars over the next year in the community, so I'm very excited. I will talk about future seminars at the end. Okay, so black breast cancer. So why are we here? Black women are more likely to die whenever they're diagnosed with breast cancer compared to their white counterparts. They are 41% more likely to die from breast cancer, unfortunately. Also, black women have a 31% overall mortality rate from breast cancer. When compared to white women, that's around 20%, so it's significantly higher. And then black breast cancer patients have the lowest 5-year survival rate of any race or ethnicity. As I said, we have a lower rate compared to all minorities. And then also black women with breast cancer have a 71% higher relative risk of death. Additionally, we are diagnosed with de novo metastatic disease. And what does that mean, de novo metastatic? That means whenever we're diagnosed with breast cancer, we are more likely to already have a metastasis, or the cancer already spread outside of the breast tissue. And then also we're just as likely to have hereditary cancer when compared to other races. So that's another topic for another day, actually for May 20th, put that on your calendar. We'll be talking about genetics and genomics, but we are just as likely to have a hereditary mutation. Additionally, I'll get into this during this talk, black women have been found to have denser breast tissue compared to white women. And I'll go over this again, but having denser breast tissue does put you at risk for things being missed on regular mammograms. And then black breast cancer survivors have a 39% higher risk of having a recurrence when compared to their white counterparts also. And then when it comes to triple negative breast cancer is more prevalent within the black community. There are a lot more scientific advancements that need to be done for triple negative breast cancer. Therefore, the mortality rates are higher. The chance of relapsing or having a recurrence is higher with this disease. Black women have 3 times higher odds of being diagnosed with triple negative breast cancer. And again, there's a lot of research going into this, but early detection is really a way to try to alleviate these burdens on the community. And then just a few tidbits for those of us under the age of 35. Black women under 35 get breast cancer at 2 times the rate of white women and die at 3 times the rate of white women. I don't know do any of you in the room know anyone with breast cancer under the age of 35? Raise your hands. Yeah. So it's pretty common. I know a few of my friends who have gone through that. Additionally, 92% of black women agree that breast health is important. but only 17% have taken the steps to understand the risks. So that's why you all are here today, and I commend you for that, and I'm really excited to get talking about all of this. So again, I say all of these statistics not to scare anyone, but just to go over how can we improve things. Yes, there are issues within the medical community. Yes, there are outside factors, but I think the first step is making sure that we inform each other and that we have an open dialogue about all of this so that we're comfortable just about talking about these issues, because in the Black community and a lot of minority communities, health issues are sort of not talked about that often. So I really want to get the conversation going on all of this. So today we're here to talk about self-breast exams and early detection. Okay. So when do I need a mammogram? Anyone want to answer this question? Anyone? 40. Okay, 40. Anyone? You said yearly. Anyone else have what age? You can come sit down. Men are also affected by breast cancer. So, anyone else have another age? Age or how often? If you find a lump. Okay. Yes, that's definitely a good time to do it. But as far as screening goes, what age? 35. Okay. So, screening mammograms typically begin at age 40. And they should be done annually, so once per year. There are recommendations from a few different organizations about the age. There's a debate about 40 versus 50. Most oncology organizations recommend beginning at age 40. And then there's also a debate about annual versus every other year. But most of the oncology organizations recommend 40 and annually. Okay, so everyone in here, or most people in here, I think, should be getting them, and every year. 35, so actually getting them earlier is for patients who have a family history or a genetic mutation specifically. So whenever you have a genetic mutation like BRCA1 or 2, CHEK2, ATM mutations, those patients will get mammograms starting at age 25 to 30 and annually. And then they will also get some additional imaging on top of that, which we'll go over. So what are the issues with getting annual mammograms? I guess you all can attest to that. There's time issues. You have to deal with your family. You have to deal with work. You have to worry about insurance sometimes. So there are a lot of things that prevent everyone from going to get a mammogram. In addition to that, there's the fear, like, what if they call me back? What if there is something? So let's go over what exactly we're seeing whenever we're doing a mammogram. This is not meant to be a course or anything on radiology. This is meant for you to understand what's going on. So whenever the radiologist or the radiology techs are performing the mammogram, they want to make sure they get your entire breast image. On the right, you can see there are pictures of a breast. The first image is looking at the breast from the side, and then the second image is looking at the breast straight down. So they always want to have a few different images so that they can make sure if they do see something that's concerning, that they see it in all images. Screening mammography has been proven to have a 33% reduction risk in breast cancer mortality. So these screening mammograms are very important. And then also, what if you get called back? So we'll go over that, but 3D mammography can help prevent you from getting a call back. A lot of times they'll do a 2D where they do those two images. 3D helps you to see more of the images because it's sort of scanning the breast rather than just getting a still picture. So whenever we're looking at the mammograms, there is a line on your report that tells you the density of your breast tissue. And we're looking to see if there's a lot of tissue, such as on the right, that's when it's extremely dense, and then it goes down to almost entirely fatty. Does anyone in here know their breast density? No? No. That's a great point. So the comment was, I assume that my breast tissue is not dense because no one has told me that it is dense. However, a lot of providers don't necessarily disclose whether or not your breast tissue is dense, but there has been a recent update with the FDA stating that you must be told your breast density on your mammogram report. And this is very important. You have a question, sorry?
I do. So I just had a mammogram. So they did say that my breast was dense. But I didn't see anything else other than that.
Right. Great question. What is the next step? Yes. So thank you for asking that. So whenever it's important that you know your breast density because there are other steps to make sure you're properly screening your breast tissue. The reason that the FDA made these changes is because it's important to know if you have more dense breast tissue because, as I stated before, you do have a higher chance of a mass or something not being seen on your mammogram. It's not uncommon for someone to have dense breast tissue and for something to be found outside of the mammogram, and then you get further imaging that shows that there is something there. So to answer your question, we're looking at patients who have heterogeneously dense breast tissue or extremely dense breast tissue. Those patients, especially if you're considered high risk for getting breast cancer, are recommended to have additional screening. So what is the additional screening that you need? So you need at least a 3D mammogram, which is the mammogram that's not just taking two stagnant views, it's sort of scanning the breast. However, I normally recommend getting a breast MRI or a whole breast ultrasound. Either or for those things. Breast MRIs are extremely sensitive and they're able to pick up abnormalities that are not seen on a routine screening mammogram and sometimes even on a 3D mammogram, especially for patients who have dense breast tissue. So that's why it's very important to sort of have these conversations with your doctor and ask them, what is my breast density? Do you think I would benefit from getting additional screening?
So I always thought, and I think it was very unusual, that if you have really big breasts, that it's assumed that it's dense. Is
Right.
that correct?
So no, that's not correct. So just because the question is if I have larger breast tissue, do I automatically have dense breast tissue? And the answer is no. You can have larger breasts and have fatty breast tissue, such as I showed before, which is completely normal. But just because you have larger breasts doesn't mean that you have dense breast tissue. What dense breast tissue is, I'll go back again. So if you look at these images, you can see here, it looks sort of like a big cloudy storm within the breast. You can't really differentiate if there's something that is like a solid mass within that tissue. It's hard to see through it. Whereas fatty breast tissue, you can see through it. It's not difficult to see if there's something there. If there was something there, it would pop out at what the radiologist is looking at. So whenever we're looking at dense tissue, we're saying that there is a lot of tissue that's overlapping there, to the point where whenever you take an image, you can't see through it. It doesn't necessarily have to do with the feel of the breast. It doesn't have to do with the size of the breast. Younger patients are more likely to have dense breast tissue also than older patients, because as you age, your hormones change. So you start to have breast tissue that's more fatty. And then also, as I stated before, Black women are more likely to have denser breast tissue than white women. Okay. Why is that? That's a great question. I don't have the answer to exactly why Black women have denser breast tissue than white women. It has to do biologically with things, and we don't entirely understand why. For African American women, just like we don't necessarily understand why we are at higher risk for triple negative breast cancer. To get into the weeds, there are some germline differences within genetics from our ancestry in Africa, especially West Africa and Central Africa, that put us at higher risk for that. Any other questions? No? Okay. So everyone understands dense breast tissue. Everyone's going to go ask their doctor, do I have dense breast tissue now? Okay. So yeah, that's not necessarily the case. Yep. Yep.
And I was just gonna add that we also need to ask for the
Additional imaging. Yeah.
that regardless of what they come back and say, or they say everything's okay, that by their estimate, that we should be asking as well for the additional.
Exactly. And if your doctor doesn't feel comfortable or doesn't feel comfortable ordering it, then you should ask to see a breast specialist, or a high risk specialist, so that you can talk about your risk and know your risk for breast cancer. Yes.
I was just gonna say, as African Americans, we don't get the same treatment for, I am against.
Well, thank you.
Yeah,
Congrats.
I got on a treatment with Stanford.
Congratulations.
Really, really big advocate about very different people. And I remember getting my mammogram. When you go there, they give you the results right there.
Right. And that doesn't happen at all
It
facilities.
doesn't happen at any of the facilities. They will make you wait. But the irony of the whole thing, there was this Caucasian lady there. She says, I ask my MRI every year.
Mm-hmm.
You don't just take a mammogram. She says, no. I ask for it. I demand an MRI.
Yes, that is a very good point. So the point was made that as minorities and as African Americans, we are not treated the same whenever we go to the doctor's office, and there are definitely studies showing that there are discrepancies in that, and that is very true. That is why I think that these series are very important, so that we're educated, so we can be like the other patients who are going and asking and demanding for these things, so that we know what exactly we are supposed to receive. Great point. So let's pivot a little bit and talk about, what if I need extra imaging? What now? So I want everyone to be aware that if you do need extra imaging, it doesn't necessarily mean that there is something wrong. It doesn't automatically mean that there's cancer. As I stated before, if you have dense breast tissue, it's hard to see through things. Sometimes they have to get extra images so that they can zoom in on those abnormalities. Less than 1 in 10 women who have repeat images are actually diagnosed with cancer. So most of the repeat images are benign. It's not cancer. So why do I have to get extra imaging? It could be that the radiologist needs better or clearer pictures. It could be that you have overlapping breast tissue in some of the images that looks like it could be something, and they just need to get a little bit better picture, press a little bit harder, sorry for the mammogram, and then they can see what it is exactly. You could have a change from your previous mammogram, which could be entirely benign and not cancer. There could be a mass that's discovered. There are a lot of breast masses that aren't necessarily cancer. So let's go over what exactly they're doing. I'm sorry about the lighting, but this is basically showing that whenever they're getting those extra images, they're trying to zoom in on the area and really differentiate what things are. So they'll use compression or magnification views in order to see what's going on. Also, ultrasounds are used sometimes in order to better view the images. And then if they do see something concerning, they have a scoring system where they will, I'll go over the scoring system shortly. So for ultrasounds, why do they do the ultrasounds? It's useful to resolving findings on the mammogram. It seems sort of low technology, but it's actually extremely useful in order to see what's going on. It can evaluate cysts and masses. Here you can see there's a breast cyst there. Those are benign. And then here you can see a mass here. So they can differentiate what's going on based off of an ultrasound. And they also use the ultrasound in order to help guide aspirations and biopsies and to look at lymph nodes. So breast MRIs. So as I stated before, they're highly sensitive, and we use those in order to help screen patients who are high risk. There are certain calculators that we use in order to deem whether or not someone is high risk. And high risk means that your lifetime risk is above 20%. It's also useful for young women and those with genetic mutations. We use MRI in conjunction with mammograms. So if you have a genetic mutation, we would do annual mammograms and annual MRIs in order to help detect things sooner. It's also better at examining dense breast tissue. Again, that's typically what I recommend for my patients who have dense breast tissue, especially those at high risk, in order to make sure that we're not missing anything. Because the earlier that we catch these things, the better the prognosis, the lower chance of recurrence and mortality. And then it's also used, MRIs are used to assess whenever we give treatment, whether or not the tumor is responding to the treatment. One caveat about MRIs is that it can locate lesions that are not cancer frequently. So if you get an MRI, there is a little bit higher risk of you getting called back for something and then needing to biopsy something that's probably benign, but it picks up a lot of things since it's so sensitive. Okay, so this is just a table going over the BI-RADS score. It is the scoring system that radiology uses whenever they are looking at your images. You'll get on the report, in addition to your density, it'll also say the BI-RADS score if there's something that they find that's concerning. So sometimes they'll tell you, yeah, it's a BI-RADS 4, you need to get a biopsy, and you're like, what does this mean? So BI-RADS 4 is typically where it starts whenever you need to get a biopsy. This whole scoring system basically tells us what the radiology is thinking whenever they're looking at the images. So if they say everything's good, normally it's a BI-RADS 1, so they don't even bother telling you the number. Whenever it's a 4, that's when they think that there could be malignancy there, but it's broken up into 3 groups. There's 4A, B, and C, which vary based off of their suspicion for malignancy. 4A means that less than 10%, 4B is 10 to 50%, and 4C means that they think that there's up to a 95% chance that what they saw on the image is malignant. In any of those situations, they will recommend a biopsy. Any questions about this? This is sort of a little involved, but any questions? No? Sure. It's okay. Take your time. No, so they use the BI-RADS. Every single time a radiologist takes a look at a breast image, they have to put a score on there on whether or not they think they're suspicious for something. So whenever they do a mammogram, ultrasound, or an MRI, they will put at the bottom of the report, they will put a score. So if they say, hey, looks good, nothing's there, then they'll either put a 1 or a 2. If they think there is something there, but very, very low chance that it's actually anything, then they'll call it a 3. And in the situation where it's a 3, you'll need to get more imaging at 6 months intervals for 2 years before they say you don't need to get extra imaging anymore. You can just go back to your annual imaging. And then if they think it's concerning, then they'll give you either a 4 or 5, which means they really think that there could be something there and that it should be biopsied to determine what exactly it is. If you get a mammogram, there will be a BI-RADS score at the bottom of your report. Some places put it at the top, but normally it's at the bottom. Probably. It's a lot of long words, but yes. So yes, it'll tell you on there. Any other questions? Okay, so we're going to switch gears now and talk about self-breast exams, and then we'll have Keisha Stephanie come talk with us about her journey with everything. But let me go over the self-breast exam really quickly. So how many people in here have done a self-breast exam? Oh, that's good. I'm pleasantly surprised. Okay. Normally it's not that many people. So let's just go over the breast anatomy. So I think this is just helpful for you to know the extent of where your breast tissue is. So the boundaries of the breast are your clavicle, and then it goes down to below your breast. This is called the inframammary fold. And then it goes, your breast in the middle goes to your sternum or your chest bone, and then right in front of where your armpit sort of starts. The breast is drained by lymph nodes. We call these the axillary lymph nodes, or the lymph nodes that are underneath the arm. So that's also important. That would be the first place that any cancer would spread if you did have cancer. So when you're doing your breast exam, the first step that's important is to look at everything. You want to look to see if there is any changes within your nipple, if there's any nipple discharge, any skin dimpling or puckering where there used to not be any skin dimpling or puckering, if your nipple used to go out and now it goes in. Things like that are signs that you should warn your doctor about. So whenever you're performing your breast exam, so you want to perform it in 2 different positions, upright and laying down. So you can either be standing up in the shower doing it, sitting down but sitting straight up, or just standing. And then you also want to perform it laying down. And the reason for this is because you can feel different depths a little bit easier in different positions. And whenever someone is performing a breast exam in the office, they should be doing both sitting up and laying down also. So everyone, I want you to pull out your dominant hand, right or left. I don't know who's left-handed. So you want to use the pads of your fingers. You don't want to push with the balls of your fingers. You want to use the pads because that's where you feel things. And you want to have, typically they recommend having your arm up, and then you start from your clavicle and work your way around your whole breast. And don't do this. You want to press, and you want to do lightly, and you also want to do deeper, because you want to make sure you're getting anything sort of surface level, and then you also want to make sure you're feeling the deep parts of the breast tissue. And then one other thing that's very important is feeling underneath your arm and your axilla, because again, that would be the first place that breast cancer would spread if it spreads normally. Does anyone have questions about that? Yeah? Thank you. Question? Yes, so you're feeling if there's a lump, if there's something that was there that wasn't there before, you really need to know like your baseline. Some people have lumpy breast tissue, so or what's called fibrocystic breast tissue. So you need to know what your baseline is. If there's a lump that's hard, not moving, those are signs that it's concerning. If it's a lump that's been there for that you've always noticed, you should still get it checked out if it's just like one lump. And you should also you should tell your doctor and get it checked out. The workup is different depending on your age. If you're under the age of 30, then they'll start with an ultrasound. If you're over the age of 30, then they'll do a mammogram and an ultrasound. But good question. Yes. So you're feeling for something, a mass, something hard. Sometimes it can be something that's small, but you need to know your baseline. So the recommendation is doing these once a month. We have shower hanger cards in the back for everyone to grab, and you can hang on your shower. It's the pink card, and there's a punch out on there so that you can keep track of each month that you do it. Aaron's holding it up. So yes, I'm glad that mostly everyone here does them, and definitely recommend in order to, because a lot of patients, about 40% of breast cancers are found from self-palpation or outside of your regular screening mammogram. So it's very important to do these. Question? Mm-hmm. Great question. Yes. So it's not necessarily soreness. Breast cancer, a lot of times you don't have pain unless it's spread or very large tumor. And then it should be, so if you do have an infection, it is common for your lymph nodes to be enlarged anywhere in your body. Also, if you had your COVID vaccine or booster, that definitely causes underneath your arm to have lymph nodes that are swollen. So it's not a good time to check under your arm. But outside of that, yes. So if you felt something under your arm from those sort of infections, it's a similar sort of feeling within the breast tissue. But you're feeling for a mass or something that normally, so we have models in the back also for you to practice with, but normally for breast tissue, you'll just feel fatty tissue in there. And then if you feel something like, oh, I didn't feel that before, and it feels like a lump, feels nodular, sometimes it's hard, then that would be something to bring to the attention of your healthcare provider. Any other? Yes. Right. So I would recommend, I don't know the specifics of what they saw, but if you have a palpable area underneath the arm, did they do a, they did, and they did this. So yeah, if the ultrasound, if they didn't think it looked concerning on ultrasound, then they won't typically biopsy it. If you're not happy with things, you can always seek a second opinion so that someone else can look over everything. But I think you would have to see what the biopsy showed in your breast first, and then that may prompt them to do more. But you should, if you don't feel comfortable with what they're doing, then I definitely recommend getting a second opinion. And just to be, it is your body. You're allowed to get second opinions in this sort of situations. You wouldn't like go buy a house and without like seeing multiple lenders. Like it's your health. You need to make sure that you're making the right choice.
Could you have multiple masses?
Yes, you can have multiple masses in your breast that aren't cancer, especially in patients who have fibrocystic changes of the breast. Some patients have what's called fibroadenomas, which can form frequently. They're not cancer, um, and um, and sometimes they multiple of them occur. So yeah, it's very possible for you to have multiple masses and it not be cancer.
Just thinking of piggyback.
Hmm.
Back on the question that you just asked about how many months of your breast goes to the breast. If the breast, they said it's one cancer, but, and the lump is still there, do you think you'll recommend putting a biopsy every 7 weeks?
So I would have to say I would treat that on case by case basis. I'd have to know exactly what the pathologic diagnosis was from the biopsy in order to say whether or not it absolutely needs to be removed. I need to know the size of it. There are a lot of different factors on whether or not I would recommend removing it. Um, so, so yeah, I mean, I can speak about specific patient like situations like with each patient, I guess. But there are a lot of different scenarios for that. So,
That's true, because breast cancer don't cut the process, because everybody is different. But this is just kind of information, that's important. It's very bad to know the brain,
mhm,
that they have questions to kind of direct them information to.
right. So, I mean, if they have a mass that's there and you're saying that they recommend to not remove it.
I would let know, I just want to let know, but the breast
Oh,
is
okay.
okay, and if there is a problem, and they said let know it's okay, but the lump is still there.
Hmm.
Would
Um,
you probably go back and have them to biopsy that lymph node where the lump is, or just,
so the radiologist won't necessarily biopsy something just because they have to go back to that grading system, the BI-RADS, on whether or not they think it's concerning. If they don't think it looks concerning on imaging, then they wouldn't recommend biopsying that area just because all of these procedures have risks. At that point, if it's low risk for it being malignancy, then doing the biopsy would be higher risk than necessary.
thank you for the information on the biopsy. I didn't know that either.
Of course, yeah. Okay, so I think we'll move on. I'm just gonna put up this last image. I'll talk about this later, but we have breast models in the back for everyone to practice doing self or practice doing a breast exam on. There are nodules that are hidden in there. So we'd love for you all to participate and try it. It takes maybe 5 minutes. So, but take home points. So annual breast screening begins at age 40, and we recommend annually. You need to know your breast density, and if you have extremely dense breast tissue, then recommend getting a breast MRI. And then I recommend monthly self breast exams to all of my patients. Make sure you take one of those the hangers. And you are your best advocate. So if you ever feel like you're not getting the care you need, feel free to speak with patient advocacy at your healthcare provider's office or ask for a second opinion. It's okay to do that. Okay? Exactly. Yes. Thank you, Latanya. So, without further ado, I will have our next speaker come join us, Keisha Stephanie. She is our lovely survivor who is going to give us a talk about her journey. Okay? Thank you, Keisha.
Good morning, everyone. Thank you so much for having me. I am excited to share my journey with you all. I told Candice when I got here, she said, share as much as you are comfortable with. And I told her I'm comfortable with sharing it all. So I don't have a problem with that. So in a lot of the information that she just went over, it just like stuck with me because it felt like it was just all part of my journey, right? I am a stickler for exams and making sure that I am going to get my mammogram and, cervicals and everything. Like, I think I joke and say that Kaiser has a red flag on my account because I always ask for stuff. But so in 2020, I was due for a mammogram. And as we all know, COVID, right? So they put everything on hold. And I didn't think nothing about it because I had been getting my mammograms like I was supposed to, and they all came back. They were all normal. So when it opened up again in January of 2021, I went ahead and, they said, oh, we only have one in April. And I was like, oh, it's January. Okay. So I went ahead and took it. Right before then, I had the vaccine. And when I had the vaccine, right before when they called to confirm the appointment, they asked me, have you had the vaccine? I said, oh, I did. And my lymph node, they're a little swollen. And she goes, well, we may want to hold off. We're telling people to hold off because of the false negatives and things like that. And then it dawned on me, I'm like, oh God, it took me 4 months to get this appointment. If I hold off, it's going to take it. So I told her, I said, nope, I'm coming anyway. If it's false and you call me back, we'll go with it. And thank God I did, because I went in April of 2021 and I was diagnosed with stage 2 triple negative breast cancer. I was devastated, scared, just didn't understand. Like, I was very healthy. I had just a couple of years before then, I had decided I was going to get in the best shape of my life. I was in probably the best shape that I had ever been in my entire life. I just, was eating good, probably about 85% of the time. So, I didn't understand. I remember them calling me that same day with the results. And I was like, oh God, this is Kaiser calling? Like, they don't call back like that. And I start, what's going on? We need you to go to Oakland. So I was like, okay, maybe it's the COVID vaccine, right? Maybe that's what's going on. So I called my husband and I told him, I said, they want me to go back to Oakland. Oh, he's same thing. Oh, you're fine. He always says that. You're fine. I went to have the ultrasound done. And, I kind of, the next day actually, and everything happened very fast. And when I was in there, it felt different, right? When they started examining and looking and doing ultrasound, like, you can just I got this vibe. It was this weird vibe that I had never had before. And I started getting worried. And then they had me hold on, and then, and then they come back, oh, well, we want a biopsy now. And I'm like, okay, now I'm really worried. Like, what's going on? So all in all, I spoke with the nurse navigator, is the one who actually told me that it was a possibility, right? That they were pretty much about 95% sure that it was breast cancer. I remember like getting in my car, and before I even called him, I just like had this breakdown because I'm just like, why? How? You know? So I ended up, I had to have 16 rounds of chemotherapy. And so I went through the chemotherapy process, which was it was tough. It was really tough. It's not something that anyone can really prepare you for. They tell you what to expect and the side effects and things like that. I remember going into this. I had braids like this, and I remember, I want to say it was the week, second or third week of therapy, and I walked in, and one of the nurses, they were all nice, but she said, "Oh, you still have your hair." Right. And I'm thinking to myself, well, am I not supposed to have my hair? Like that was, you know, and then I went to see for my oncologist for a follow up, and she goes, "Oh, you still have your hair." Right. She said this is the same week. And I'm thinking to myself, well, maybe I'm gonna keep my hair, and I believe it was that weekend. I kind of did something like this, and I could feel it, kind of peeling off. So I just told my husband. We talked about it, and I'm like, let's just cut it, And so that was probably the most traumatic experience ever. And no matter what someone tells you, it's just hair. Yeah, but it was mine, right? And I would have not went bald by choice. It's beautiful. A lot of people do it. That was not. I wasn't. I didn't want that, and I felt like that decision was taken from me, and I was angry. So I did the 16 rounds of chemotherapy. I opted to have a bilateral mastectomy because I just wanted to, you know, the reoccurrence, everything was scaring me. So I'm like, take them both. And then you start thinking about how they're going to look after, and is this one going to look different? I'm like, you know what? I want them as close to, as I can get, that look the same. And honestly, they were 51-year-olds, so I wasn't mad at letting them go. If I'm being honest. So I was okay with it. Him and I spoke, and he's been great, and he's like, hey, as long as you're here, right? And so that support was amazing. So I made a decision to do that. And then I had that done, I want to say day before Thanksgiving of 2021. I then went through 25 rounds of radiation after. So they did treat it very, very aggressively because it was the triple negative breast cancer. So when I had my surgery, they put in the implants at the same time, or expanders, I'm sorry, which are horrible, by the way. And my right side, it just had an attitude. So it was not the cancer side. It just had an attitude. And so I had an infection that set in. And this was, even with all the chemotherapy and everything, it was the surgery that I battled the most. So when the infection set in, we had to have it taken out. Now she talked about being your own advocate. So I know my body inside and out. I know if something's wrong. I know if something doesn't feel right, and I remember telling my husband, I'm like, this one doesn't look right. Like the coloring is off. Like it's just not right. And so I called my plastic surgeon and I told her, and it's always, well, you're gonna have some discoloring because of the drains and things like that. Well, ultimately, I ended up just making an appointment with her. We went to see her, and then when she saw it, she was like, "Oh, right." And so I won't give you the gory details of what happened that day, but in that office. But it traumatized me what she did in that office. I ended up leaving out of the office like this because all this stuff was on me, and she's like, "We have to get you to surgery, to get it out." But if you would have listened last week when I told you that something wasn't right, So I ultimately had to have that removed. So I was flat on one side and had the expander on the other side for, gosh, it had to have been about maybe 5 months or so, I want to say. And then that was an awful experience for me. They gave me a prosthetic that was pink, right? And I put on a happy face and put it on when I needed to have it on, but I just didn't feel right. I didn't feel myself. I just didn't like it. So I couldn't wait to get reconstructed. And I know a lot of times people they take different roads with it. Some people don't want to get reconstructed at all, and whatnot. I just, for me, I didn't, I wanted to get reconstructed. Fast forward, I did get, let me see what happened. I've had so many surgeries, you guys. Like, I feel like Frankenstein under here. I mean, really. So once we made the decision again to try to, when I had the expander removed here, when I was going to do the exchange, that she would put the implant or an expander on this side, if doable, if we were able to. And so we got in there, had another surgery, and this was end of last year, and in November, I think. And so I had the exchange, and she had to put another expander on this side. So I was like, oh, that means I got to have another surgery somewhere down the line. But at least I wasn't flat, and I felt, a little bit, like myself again. So in February of this year, knowing myself and my body, I was sitting up at our little bar in the house, and I kind of was doing this here, and I was like, oh, what is that? So I had him feel it. I was like, do you feel that? And he goes, yeah, we got to get it checked out. And I had already had some concerns because I had cut my finger. Was it my finger? I think it was my finger I had cut. And it was, I thought it was like infection setting in because, like you said, sometimes you get infected, your nodes will start to swell. So went in to see my primary, and then she did the exam. And, I got that feeling again. And she's so great because she's so soothing and she looks like me. And so she understood, and she said, I'm good, we're going to get on it. And I mean, before the day's end, I had everybody calling and trying to get me set up. And it was discovered that I had a reoccurrence. So that was February of this year. And I was again angry because it's on the opposite side. And how to get over there. So that was the scary part for me. But God, because it got over there, but it didn't touch that organ. So I'm in the middle of radiation again right now. I will do 25 rounds of radiation, and I'm on 12 as it stands now, and I will have to take some oral chemotherapy afterwards. But I had the surgery to have the lump removed. They took some other, which is called a axillary dissection. Am I saying that right? Okay. And so they did that, and then there was nothing else. It didn't go anywhere else. And so right now I'm still in the fight. There are some days that I feel tired, and not of the process. I was just telling him the other day, I said, it's been 2 years that I've been fighting this some way or another. And after a while, it does take its toll on you, you know. But the positive thing about it is that both times I found it was because it was early detected, and I was able to save myself, right? So I'm just an advocate for knowing your body, making sure you're doing those screenings, your self exams, and making sure that you are going into getting your mammograms, and making sure that if you feel something wrong and you know it's wrong, then you make sure that you let them know and you don't take no for an answer, and it's okay, right? I always have him laugh all the time. You see that we talk all the time. It's my best friend, so I always tell him I laugh. But he's thinking right now I'm not your best friend because he tells me you need some women friends. But no, I tell him, like I always have him laugh. I'll be like, I'm getting my exam. I pay good money for Kaiser, and they're gonna see me and do, So just make sure that you don't take your health for granted, because you just never know that might not be something, might be something, and then you wait too long, and then you're in a different path, right? So I just kind of like to share, and like I told her, I'm an open book. I started sharing my journey on social media, and I have quite a few followers that they need that outlet to let us, so we know that we're not alone out there, because you're right, in our community we don't talk about it enough. I had gotten genetic testing, as I have a 33-year-old daughter, and I was concerned, you know and when they started asking me the questions, when the genetic counselor started asking me the questions, I remember having a little breakdown and telling the lady, white lady, and I felt bad and embarrassed, but I told her, I just don't know. I don't know my family's history. Why don't we know that? Like, Aunt May died, but we don't know it was natural causes. What? Everybody don't die of natural causes. Not everybody. We got something. What is it? So I just made it my goal for that to stop with me. So I share, and I hope you will too. So.
Well, thank you, Keisha, so much for sharing your story. Really appreciate it. And it really underlies what she said. Early detection, both times she pushed for that mammogram that she knew that she needed. And then she also found the lump in the other breast and pushed for more testing for that. So that's why we're all here. So again, thank you all for being here. Just a few other housekeeping things. You deserve the best medical care possible. If you think that you're not getting the best care, go get a second opinion. And make sure you bring someone with you also, so they can advocate whenever you're in shock or lost for words. We have these wonderful models in the back that I want everyone to try. So while you're waiting, you can get food and drinks, but these breast models, well, I'll be back there helping out, but it's in order to help you with feeling all of the breast tissue. There are masses in some of them and not in others, so we'll see whether or not you are successful in finding the mass. So definitely go back there and try those. And then if you are interested, you can scan this QR code. Our next event will be May 20th. It will be at Beth Eden Temple here in Oakland. And it'll be from 10:30 to 12 again. There will be food, so scan, sign up. Hopefully you'll join us again. And the topic is genetics and genomics. Does anyone know what genomics is? Even more reason for you to come. So I'm going to have Pamela Ratliff come speak. She's been extremely helpful with this whole event. And she is just going to talk about a few other events and imaging. So thanks, Pamela.
Thank you so much, Candice. And again, thank you to all of you for attending today. You could have been anywhere, but you chose to be here. So I just want to celebrate you for making your wellness and your health a priority. So thank all of you. And I want to send a shout out to the mothers and daughters too, because it's important for us to pour into our next generation and the granddaughters who are here. So we want to encourage you and inspire you and expose you to this field of oncology. So thank you as well. And to the gentlemen, I don't want to leave you all out, for supporting this important cause. So I'm just going to briefly go over a few resources that we have available. We have some great resources that were out front when you entered from our wonderful partners at Touch. So please feel free to take those. In addition, inside we have some resources from our Stanford Imaging. So I'm super excited to talk a little bit about those resources as well. Erin mentioned earlier, actually showed you all earlier, we have some breast shower cards. So please feel free to take these. The breast self-exam shower cards, you can use them every month. You can actually press out the little hole at the bottom to keep track of yourself doing your breast self-exams so that you can monitor what's normal for you, and if any changes, quickly report those to your healthcare provider. Also, our imaging and radiology department provided us with this wonderful guide. It has information for patients and families. And this is really a detailed guide that shows all of our imaging services. So if you haven't received that, please do. And in the back is a handy chart that shows the locations and the modality of services. So it includes Stanford Healthcare in Palo Alto, Emeryville, Tri-Valley, which includes Pleasanton, Livermore, as well as Dublin. So please feel free to take one of those. Next, we also have a wonderful flyer that I think is so important for those of you who are outside of Stanford Healthcare to have. If you plan on getting imaging services at Stanford, would like to transfer them, this is a wonderful step-by-step instruction guide that tells you how to do that. So please don't leave without taking that if you're considering doing a second opinion as well, which we do have services for that. Then we have a general breast imaging guide that talks about breast imaging and the different types, including 3D mammography. And it also on the back talks a little bit as well about breast density. And we have also the new flyer, which talks about screening automated whole breast ultrasound. You heard Dr. Thompson mention that earlier. This is a wonderful flyer that talks about that technique in detail. So please be able to make sure you get these resources. And if you know someone who you can share them with, we encourage you to do so as well. The last thing I want to talk about, some of you I know from this event. This is our annual conference on breast cancer in African Americans. The 12th year is this year. We're returning in person. Must come to event if you've never attended the event. We really cover the spectrum of breast cancer, everything from early detection, awareness, on through treatment options, clinical trials. We're going to have Dr. Thompson speaking on that topic, as well as survivorship, alternative therapy, stress, physical activity, mental wellness, anything you can think of that's breast cancer related or connected, we will be talking about. We'll have wonderful exhibitors who represent organizations who provide low or no cost breast services at the event as well, and speakers from all over the country who represent the Black and African American community. The event is free, so there's no charge. There's a wonderful, like I said, this is not a shower card, but it is a door hanger. And on the back, there's a reminder about breast self-exams on the back. And on the bottom is the contact information if you'd like to email me to be added to the mail list. So I hope we'll see some of you there. Bring your daughters, bring the young women. We want them to volunteer. We want them to get involved. And again, it's so important for us to fill these seats too at these sort of events that are happening monthly. So tell other women in your community, encourage them to attend, because we have to take stock of our health in order for us to be even thought about or considered when we go to the doctors and go to the hospitals. So it's time for us to stand up and make a difference in not only our lives, but those of our children and our other connections and our other community members in the future. So thank you all so much.